Thanks, everyone. Yeah, my name's Lucy, and as Mark said, I'm here to talk to you about attitudes of professionals to smokers with mental health conditions, but also attitudes to smoke-free policy. Just a quick bit of background. These findings were actually part of a wider study I did at ASH as a larger report in response to gaps in training of psychiatrists and mental health nurses. And this research was done in 1999, gosh, 2019, I'm old, but not that old, and February 2020. So just keep in mind, this is pre-COVID lockdowns, so any shifts in attitudes or policy won't be accounted for in these findings. It does focus on mental health nurses and psychiatrists. We do acknowledge there's lots of other health professionals that contribute to health outcomes, but we didn't really have the capacity to focus beyond those two professional groups. And just quickly what we did, we held some focus groups with psychiatrists and nurses, but also ran a national survey. We had about 500 respondents, but only 265 of those were included in our final analysis. So I'll be covering staff attitudes and beliefs, but that covers things like patient motivation to quit, attitudes towards smoke-free policy, and also the role of smoking in mental health settings. But also I'll be touching upon some of the organisational barriers that came out of the research, things about pathways and support across settings, lack of alternative activities, and policy compliance. So to start off, staff attitudes and beliefs, what did we find? Well, one of the first questions we asked in the national survey was agreement levels to the statement, patients with mental health conditions are not motivated to quit. And as you can see, these bar charts show the responses in 4 different professional groups. You've got inpatient psychiatrist, community psychiatrist, and then inpatient nurses and community mental health nurses below. And the responses were, I don't know if patients with mental health conditions are not motivated to quit. I strongly agree they're not motivated to quit. I agree, disagree, and strongly disagree. And they go from left to right. So encouragingly, the majority did disagree or strongly disagree that the patients are not motivated to quit. But we still had a third overall, who didn't know, or they strongly agreed, or they agreed that patients were not motivated to quit. And keep in mind the evidence that we had this morning that actually, people are motivated to quit. People in inpatient settings were more likely to agree or strongly agree that patients weren't motivated to quit, and perhaps that's a reflection of the acute nature of the job or the severity of condition of their patients. We also asked, do you ever discourage patients with mental health conditions from stopping smoking until after their mental health improves? Now, this is the pooled result from everyone, and the answers from left to right is that we always discourage patients from stopping smoking. We usually discourage, sometimes discourage, rarely or never. From left to right. And again, encouragingly, majority say they rarely or never discourage patients from stopping smoking until after their mental health improves. But again, 30%, it's quite a big chunk, say they always, usually, or sometimes discouraged patients from stopping smoking until their mental health improves. And again, think back to the evidence this morning that quitting smoking improves mental health. Then the focus groups go some really deep insight into people's kind of beliefs about the role of cigarettes and smoking, especially in the inpatient setting. The first was that a lot of participants found, it had a really strong social value, a social role in the inpatient setting, a positive social role, should I say, in that, this top quote says, it's a currency on the ward, like a social fabric that people socialise over. It's part of their culture, almost, getting to know one another and forming groups. The second key thing that came out was that people, and again this was mentioned with other speakers, that professionals found that they could see a therapeutic benefit to smoking, the role of smoking, and that actually it had some positive kind of point to their relationship with the patients. This middle quote says, there's a lot of cynicism about smoking cessation among staffs because they actually see some therapeutic benefits in those cigarette breaks in terms of their therapeutic relationships to the patients. And then lastly, there was a very big kind of sentiment that actually cigarette played a role in the day-to-day management of the patients in the daily routine, and that was helpful. So it was helpful in sorting out some irritations and some maybe minimising violence or aggression, or it really helped in forming a routine for the patient to making sure that nicotine or cigarette, should I say, was available. And then a very big thing was and again this came up in previous presentations, was that there was a perceived conflict between how people perceived smoke-free policy and their inpatient staff values. So everyone acknowledged that smoking was a health risk, thank God, but that didn't translate into universal support to smoke-free policies. I mean, there were a cohort of people that it did, but predominantly it didn't. And so despite the health promotion rationale for smoke-free policy, the language used when people were talking about it was the negative connotations of prohibition, sanction, ban, and all of those kind of things. And when you dig a bit deeper, it was because they felt it undermined the role cigarettes played, in the previous slide, that it had a role to play, and the smoke-free policy undermines that. That it negatively impacted on patient experience, that it negatively impacted on that patient-staff therapeutic relationship I mentioned, and that they perceived it increased the incidence of violence and aggressive behaviour. And again, they also felt smoke-free policy goes into the age-old argument of limiting personal freedom and enjoyment. And these two quotes speak to that sentiment. The psychiatrist said, I mean, at the same time, when all of someone's liberty is taken away and the ability to go and smoke, but with the one thing they still have some control or choice over. And this consultant says, they're stuck in hospital, smoking might be the only thing that they enjoy or that they find relaxing. So, there's a balance to be struck. Again, no mention of it being a health risk or bad for health. It's about enjoyment and personal freedom. But interestingly, there was conflict between professional groups. So it was not all doom and gloom. Lots of people spoke about it in a very positive way, smoke-free policies in a very positive way, how important they were. It was mainly the mental health nurses that spoke of it in a positive way. As you can see from this top quote, it's a subject that's really important and improves the quality of life for clients. Unfortunately, there were some really strong opinions about smoke-free policy, extremely strong. I'd like to say this is a unique extreme, but it's not. This was from the survey, and it's in the free text box of opinions, and this psychiatrist says, whilst completely supporting training for staff and all assertive supportive measures to help patients stop smoking, I believe that the smoking ban in hospitals is immoral, overly authoritarian, and deeply damaging to the engagement and therapeutic care of many patients. I wholeheartedly oppose it. And then beyond that, there was definitely a feeling that addressing smoking perhaps wasn't in their professional remit in a mental health setting. Not every staff member. In fact, most people said that they reported smoking status. Usually mental health nurses then reported they went on to address something, whether it was signposting or speaking about smoking cessation support. But psychiatrists definitely felt that it was outside of their professional remit because it related to physical health, as they saw physical health, and didn't relate to mental health. And I think this psychiatrist really kind of sums it up nicely that, he says, I think the issue is partly there's a culture in psychiatry, which means we're not responsible or we don't deal with physical health, and that we will do some aspects of it, but not very much. So I'm going to move on to some of the organisational barriers that came out of these findings. The first, and it's been mentioned earlier, was that there's a lack of consistent support across settings and services. So what I mean by that is support from inpatient community, but also from inpatient community to then going to a GP and seeking some help. A lot of inpatient staff felt that community staff weren't very supportive in smoking cessation journey, perhaps in preparing an inpatient for a smoke-free stay or maintaining a career after discharge. But really importantly, it's important to highlight the community staff felt that smoke-free policy wasn't relevant to them, it didn't relate to them because it was written for inpatient staff in mind. And this mental health nurse says, we noticed 18 months in of being smoke-free, what is desperately lacking is that community-based support. It's missing from the smoke-free programme in that trust. And again, one of the things was that it was felt there's a lack of alternative activities. I mentioned that people felt that cigarettes played a really important role in the daily routine and structure of a day, and that actually, without a cigarette break, what else do people do? And this psychiatrist is saying, it brings structure to the environment, it creates a timetable in the day, and perhaps there should be some thought for the inpatient teams for actually what to do instead, about, what else can we provide, what activities we can provide to relieve boredom that take the place from cigarette breaks. And then lastly, policy compliance. This was spoken about in a couple of ways. The first way was that there was an unspoken kind of agreement that trusts would go against policy in a way to mitigate the perceptions of adverse consequences of smoke-free policy. So for things like they felt that they didn't want clients or service users to go out and smoke on a busy road, or they didn't want to damage a therapeutic relationship, or they thought that might be a danger of increasing violence and aggression in the ward. So there's an informal agreement to kind of, breach policy. But the other one was that it actually created conflict between staff members. So you had those that complied to policy and those that didn't comply to policy. And actually there's a real tension between that. And as this mental health nurse said, it's what makes it slip, as in the support, is the heroes who say to patients who smoke, look, just go out there, have a cigarette, I'm not going to say anything to anyone. And what they do is they undermine it for absolutely everyone else. So to sum up, staff totally understand the harms of smoking and the inequalities it drives the client group. Luckily, that's not the issue. The issue is it really appears detached from the understanding of the health promotion rationale of smoke-free policies. And so these negative beliefs, which evidence contradicts, are likely to create or maintain those barriers to addressing smoking. And those ideas that people with mental health conditions are not motivated to quit, that smoking plays a role in the culture of mental health settings, that the policies are unethical, and actually, smoking is not the role of mental health professionals. And with these barriers, on top of that, we have organisational constraints that certainly don't help. And what do these findings tell us? Well, they mirror previous evidence and literature on staff attitudes, beliefs. They've mirrored things that have been said in the room this morning in presentations. That these attitudes towards smoking cessation, smoke-free and permissive attitudes towards smoking are still major barriers to change. And that whilst sometimes they can be addressed by training, because they're underpinned by kind of organisational culture, change won't be achieved through just training alone. And what it also says, the importance involving patients, service users and people with lived experiences, so we hear and understand their stories. So that's from designing interventions or writing policies, just to making sure their voice is heard and used. I'm going to just quickly leave with this quote. This is a psychiatrist who at the beginning of the focus group didn't know why he was there because it was smoking and he was a mental health practitioner and he, smoking was a physical health thing. And actually, I don't really believe in smoke-free policy. And he kind of changed his mind at the end. He kind of went through a reflective process and he realised that his view on people with mental health conditions that smoke was actually a bit patronising. And he said, this notion we have of the poor mental health patient who, doesn't have much going for them, and the only joy in their life is their packet of cigarettes, and who am I to take that away from them? I think it would be worth having some kind of training to challenge our own beliefs of people's potentials. It's just like we have a biased and slightly patronising viewpoint, but at the same time, it kind of represents the model of care that we're giving people, that we think the only solace they have is in a cigarette, which doesn't really reflect well on us. And that's me.